The neonatal respiratory distress syndrome pathology image demonstrates the devastating consequences of surfactant deficiency within the immature pulmonary architecture of a premature infant. The primary driver is the lack of dipalmitoyl phosphatidylcholine, which is the major component of surfactant synthesized by type 2 pneumocytes starting around week 26 of gestation. These cells contain lamellar bodies that store and release surfactant to decrease alveolar surface tension. Without sufficient surfactant, the alveoli succumb to the law of Laplace, where the pressure required to keep an airspace open is inversely proportional to its radius. This leads to diffuse microatelectasis and a decrease in functional residual capacity. The infant presents with tachypnea, nasal flaring, intercostal retractions, and expiratory grunting, which is a compensatory mechanism to maintain end expiratory pressure. Risk factors shown through clinical correlation include prematurity and maternal diabetes, because hyperinsulinism in the fetus inhibits the action of cortisol on surfactant synthesis. Conversely, intrauterine stress, such as chronic hypertension or ruptured membranes, can paradoxically accelerate lung maturation via endogenous corticosteroid release. On the radiograph, you observe a classic ground glass appearance with visible air bronchograms and low lung volumes. The histopathology shows the characteristic eosinophilic amorphous hyaline membranes composed of fibrin and necrotic epithelial debris lining the collapsed alveolar ducts. These membranes create a formidable barrier to gas exchange, resulting in a right-to-left intrapulmonary shunt and significant hypoxemia. Complications of this condition and its treatment are high yield for boards, including persistent patent ductus arteriosus due to hypoxia and the development of bronchopulmonary dysplasia from prolonged oxygen toxicity and barotrauma. Retinopathy of prematurity is another risk associated with therapeutic hyperoxia, which triggers vascular endothelial growth factor expression upon return to room air. Management relies on antenatal administration of dexamethasone or betamethasone to the mother to stimulate fetal lung maturation and postnatal administration of exogenous surfactant. Neonates who survive the initial insult remain at risk for necrotizing enterocolitis and intraventricular hemorrhage due to the fragility of the germinal matrix in the setting of fluctuating cerebral blood flow and respiratory acidosis. This complex interplay of biochemical deficiency and mechanical failure defines the lethal potential of hyaline membrane disease in the newborn.